Case study: Mr. Jr., 58-year-old male, past medical history is type 2 diabetes, poorly controlled. His hemoglobin A1C is 12.4, peripheral neuropathy, chronic kidney disease, stage 3, hypertension, previous diabetic foot ulcer history, and a smoker 1 pack a day for 30 years. His chief complaint is my foot started turning black and the pain suddenly got worse. So he presented to the emergency department with a rapidly worsening left foot ulcer, severe swelling, black discoloration of the toes, foul odor, and a fever and chills for about 3 days. So, his history of present illness is 2 weeks earlier, the patient stepped on a nail while walking barefoot outside his home. Because of the diabetic neuropathy, he never felt the injury. He cleaned it himself and then continued walking on it. Then, within days, he started having redness, swelling, blisters started, and tissue rapidly darkening. He initially treated it urgent care with oral antibiotics. It was presumed bacterial cellulitis, but despite the antibiotics, the necrosis worsened dramatically. The pain became disproportionate, and there was a new black eschar forming, and drainage became quite thick and bloody. His vital signs is temperature of 101.9, heart rate is 118, blood pressure is 94/60, and respiratory rate is 24 per minute. So the patient appears to be becoming toxic and septic. Our physical findings of a foot examination: he has a large plantar ulcer under the first med head with extensive black necrosis, green gray drainage, crepitus not present, so no crepitus, dusky ischemic toes, severe edema extending to the ankle, and mild odor present. But one notable finding is that necrosis appears to be spreading hour by hour. And the rapid progression raised concerns for necrotizing fasciitis, vascular compromise, and aggressive fungal infection. His white blood cell count is 24. His ESR is 110. His CRP is markedly elevated. His blood glucose is 498, so 498. His arterial pH is 7.21. His serum bicarbonate is low. His creatinine is 2.3. So this patient is found to be in diabetic ketoacidosis. And X-ray findings, soft tissue swelling, no gas formation, so that's a sign. And then MRI findings, deep fascial involvement, extensive soft tissue necrosis, marrow edema suspicious for osteomyelitis, and vascular thrombosis. So the patient was taken to the OR for surgical, had a surgical consultation. So the physician noticed that the tissue looked dry, black, and infarcted instead of wet and purulent filled. So this appears to have angioinvasive fungal disease, okay? Mucormycosis, which is famous for invading the blood vessels. So pretty much that was the end of that. So they did do a surgical debridement on the patient, and they found that there was non-bleeding tissue, gray necrotic fascia, extensive tissue destruction, dead intrinsic foot muscles. And they took tissue plane samples, and the samples were sent to histopathology, fungal stain, and for tissue culture. Histopathology results showed a broad ribbon-like non-septate hyphae, which is classic for mucormycosis, and that is the fungal hyphae was demonstrating right angle branching, angioinvasion, and vessel thrombosis. It's very differentiated from Aspergillus. So, final diagnosis was cutaneous and deep tissue mucormycosis of the diabetic foot, complicated by osteomyelitis, sepsis, and diabetic ketoacidosis. So, I know first you're thinking gangrene and then neck flash, but it turned out to be mucormycosis. So, in today's episode, we're calling this Forgotten Infection Friday. Mucormycosis is, they call it the black fungus. And so today's episode, we're going to uncover something quite terrifying, and an organism that is aggressive, that it consumes the tissue faster than a surgeon can cut away. An infection that thrives in uncontrolled diabetes. They love acidic tissue. They devour blood vessels and it causes tissue infarction and leaves the flesh turning black. So mucormycosis, because if I saw it first, I would think neck flash, and you actually are supposed to do a tissue biopsy. Neck flash, and I would thought gangrene and vascular, but it turned out to be mucormycosis. So why is it called mucormycosis? They call it the black fungus. Older terminology used to call it zygomycosis, and I like that word better, okay? I would go with zygomycosis. And mucormycosis is the opportunistic angioinvasive fungal infection. So this is not your ordinary diabetic foot infection. This is a fungal warfare. This causes tissue necrosis, even on the microscopic level. And the infection can turn your toes gangrene-like, okay? Pretty much can turn the toes gangrene because it causes these thrombosis and stops the blood flow. So in diabetic wounds, if they get infected with mucormycosis, most likely it would lead to multiple amputations, sepsis, massive debridement, limb loss, and possible death. So today we're going to talk about this forgotten infection because these are ones that are quite rare. So mucormycosis is a rare but extremely aggressive fungal infection caused by mold in the order of mucorales, and that's the fungal environments that grow this type of fungus. So it will be in soil, dust, decaying vegetation, compost, water damaged environments, and organic debris. And the most common organisms include rhizopus, mucor, rhizomurcur, and some other ones. I'm not gonna pronounce the other ones because, yeah, it's a little too hard. So, they said the most common species in diabetic patients is called Rhizopus arrhyzus. Okay, there you go. Rhizopus So these fungi are quite harmless to a healthy patient, but in an immunocompromised or metabolically unstable patient, it can become this flesh-destroying predator. Or I remember this one patient, a story about a patient that got this infection because they had multiple steroid injections, so their immune system was actually quite compromised. So, what is the history of mucormycosis? So, this disease was first described in the late 1800s by a German pathologist named Arnold Platov. So, he documented a fatal fungal infection involving blood vessel invasion as well as tissue necrosis. He recognized that it had fungal hyphae, it had vascular destruction, and it had tissue infarction. And long before antifungals existed, initially, like I said, the disease was called zygomycosis, and I rather that, but they took the name away. But because the fungi belong to the zygomites, but later fungal taxonomy evolved and used the term mucormycosis, and that became more preferred. I guess those are people who are really great with lingo, because can I just go with zygomycosis? But why is diabetes the perfect storm for mucormycosis? Mucormycosis fungus loves hyperglycemia, acidosis, hypoxia, iron-rich environments, poorly immune defense, and ischemic tissue. This is why an uncontrolled diabetic could be one of the biggest risk factors for infection by this pathogen, especially if they have diabetic ketoacidosis. Why? Because diabetic ketoacidosis creates the perfect iron-rich environment for the biochemical factors for the bacteria to thrive on it. And we'll go deeper into that, okay? But it's about iron. So, how does this fungus enter your body? Most people acquire mucormycosis through inhalation, traumatic inoculation, contaminated wounds, burns, surgical wounds, puncture injuries, soil exposure, and natural disasters, even. And in diabetic feet, entry often occurs through ulcers, cracks, necrotic tissue, surgical wounds, callus and fissures, trauma, or gangrenous tissue. These fungal spores like to land on the tissue and germinate, and then the nightmare begins. So the pathophysiology of this fungi is actually a quite horrifying but yet characteristic invasion. So it does something called angioinvasion. So the fungal hyphae invades the arteries, the veins, and the capillaries. So the fungi actually physically penetrates the blood vessel wall. And once inside the vessel walls, it sounds like they get like a little bit like slime mode, quite smart. Once they're inside these vessel walls, they cause endothelial injury, thrombosis, vascular occlusion, ischemia, tissue infarction, and necrosis. And that's why the tissue turns black. The tissue is literally dying from the lack of blood flow, not just infection, but because of infarction. So why does the iron matter when I was saying diabetic ketoacidosis? So in diabetic ketoacidosis, acidosis disrupts the iron binding proteins. And so free iron levels actually rise in diabetic ketoacidosis. And the fungi gains access to this iron. The fungi feeds on the iron. It needs the iron rich environment. So this dramatically accelerates the fungal growth. And so in an uncontrolled diabetic, this doesn't just weaken the immune system, it feeds the fungus. So what happens in a diabetic foot that gets infected with mucormycosis? So it can mimic cellulitis, it can mimic necrotizing fasciitis, it can mimic wet gangrene, it can mimic bacterial abscesses. But then suddenly the tissue will become black, necrosis will be spreading rapidly, pain worsening, blood forming, drainage becomes foul, tissue dies, tendons become exposed, bone becomes infected. And the patient may present with a fever, sepsis, hypotension, shock, and altered mental status. So why is this one often missed? Because many clinicians assume MRSA, streptococcus, necrotizing fasciitis, or a typical diabetic infection. Meanwhile, the fungus is invading the vessels. A major clue of this is the antibiotics are failing rapidly. And another clue is the rapid black necrosis, as well as extensive tissue death out of proportion. So one of the classic appearance of mucormycosis is a black eschar. So this occurs because of the tissue infarction that goes along. So the wound may show black necrotic tissue, gray discoloration, purple ischemia, rapidly spreading gangrene, edema, bullae, crepitus, occasionally exposed fascia, and muscle necrosis. And sometimes the tissue appears wooden because the blood vessels get thrombosed. It's quite classic. I've only experienced it once. I only encountered it once in my lifetime. So, how does it spread? Mucormycosis spreads through the blood vessels, through the fascial plane, through the soft tissues, into the muscle, the tendon, the bone, and once osteomyelitis occurs, limb salvage becomes quite difficult. So there are types of mucormycosis. The major forms is rhinocerebral, pulmonary, cutaneous, gastrointestinal, and disseminated. And for us wound care clinicians, cutaneous mucormycosis is a major concern because the cutaneous disease can be superficial, deep, necrotizing, or disseminated. So how do we diagnose it? Diagnosis requires quite a lot of speed during this, okay? Because delays kills the tissue. So common findings on our labs, like in the case study we just mentioned, elevated white blood cell count, elevated CRP, elevated ESR, hyperglycemia, acidosis, and elevated lactate. What is one of the most important tests to diagnose this? A tissue biopsy. So not a superficial swab, not a simple drainage of a culture, deep tissue biopsy is quite critical, and there when you send it off to pathology, it's gonna have a hallmark of broad non-septate hyphae with right angle branching, ribbon-like appearance, and angioinvasion. So this is classic mucormycosis. And in histology, pathologists usually use a PAS stain or and a GMS stain to help visualize the high fungal structures. Okay, so the histology will reveal vascular invasion, so the angio invasion, tissue infarction, necrosis, hyphal infiltration, and thrombosis. And cultures are important, but can be imperfect in a situation because sometimes the cultures come back negative, even though there's an infective active disease going on, right? Why is that? Because the organism is quite frail. That's why histopathology is quite essential for this. Imaging is quite important because it will show us our deep fascial involvement, our osteomyelitis, our muscle necrosis, sinus tract abscess, and marrow edema. And a CT might help because it'll help identify if there's gas or not. But remember, in this patient, there was no crepitus present. Remember, that is not a reason to outroot that fascia member. And CT can also show bone destruction as well as deep spread. Now, quite a few people got diagnosed with mucormycosis during COVID. That's when I saw it, okay? But during COVID-19 in India, they experienced massive outbreaks of mucormycosis. Why is that? Because of the combination of diabetes. They have a huge diabetic population, steroid use, immune dysfunction, and hyperglycemia. And that's why it became the black fungus. And the worldwide awareness of this kind of skyrocketed a little bit during COVID, but I saw it for the first time during COVID as well. And like I said, the treatment for this is it's a surgical emergency. Mucormycosis should not be treated conservatively. It's a surgical emergency. The treatment requires aggressive debridement, antifungal therapy, metabolic stabilization. I would definitely get ID on board, glycemic control, and sometimes an amputation might be warranted. But surgical debridement is a must because you have to remove all the dead tissue, okay? Because the antifungal treatment cannot penetrate poorly necrotic tissue, okay? So that's why you have to remove it because there's no point in keeping the dead tissue. So surgery may involve serial debridement, might involve fasciotomies, might involve array resection, transmetatarsal amputation, may involve above the knee or below the knee amputation. Sometimes surgeons have to debride daily. So, what is the gold standard antifungal therapy for mucormycosis? Amphotericin B, especially liposomal amphotericin B. And why liposomal? Because it's less nephrotoxic. And this drug works by damaging the fungal membranes. There are other antifungal agents, but they may be used as a step down therapy or in a refractory disease because if the patient can tolerate amphotericin B well, okay? But many common antifungals do not penetrate the mucormycosis cell membrane well. Now, another treatment after debridements now is hyperbaric oxygen therapy. These patients can benefit well from that because it improves the oxygenation, it betters the neutrophils activity, it reduces anaerobic conditions, and it improves the wound healing. So the evidence is mixed when it comes to treatment of mucormycosis, but it has assisted in some selected cases. And our glucose control, that is a must. That should be just like knowing where your nose is on your face. We already know that. So management includes insulin, decay correction, electrolyte stabilization, and nutritional support. And remember, the hyperglycemia fuels the fungal growth as well as the DKA. So why does the amputation usually happens during this type of infection? Because tissue infection spreads, the vascular thrombosis progresses quite quickly, the bone becomes it's infected by fungus now. Sepsis develops and the limb becomes non-salvable. So the amputation becomes a life-saving opportunity, okay? A life-saving surgical intervention for the patient. Mucormycosis is quite terrifying. It has high mortality rates. Disseminated disease mortality of mucormycosis can exceed to 50 to 80%. It's because delay of treatment dramatically worsens the outcome. So every hour matters in that. So in wound care, what we can remember from this episode is when a diabetic patient presents with wounds that are turning black rapidly, failing antibiotics, becoming ischemic suddenly, progressing aggressively, develop necrosis, and has uncontrolled diabetes. Sometimes we might have to think beyond bacteria because sometimes it's a fungus instead. But I would have already gotten vascular. I would have already done the Doppler arterial duplex, got the imaging. Yeah, and so how do we prevent this? Risk reductions include strict glycemic control, early wound care, pre- preventing ulcerations. We already know that patients to wear the proper shoe gear, okay? Immediate treatment for puncture wounds. That's why you have to check your feet every day and never avoid delayed treatment, okay? And what is the future treatment for this mucormycosis? They're still researching novel antifungals, combination therapy, iron chylation research, because remember what iron does? It fuels the mucormycosis in the diabetic ketoacidosis patient. molecular diagnostic, rapid fungal PCR testing, that would be very happy. So it would be great. The future goal of it, of all this research, is to diagnose before the infarction occurs. So mucormycosis is merely not just an infection, it's a vascular destructive pathogen, a fungal thrombosis, as well as it causes tissue starvation. And on a microscopic level, the invasion actually turns living tissue into necrotic black tissue. And so for us diabetic specialists, wound care clinicians, podiatrists, surgeons, and limb salvage team, recognizing mucormycosis can mean the difference between salvage and amputation, survival versus sepsis, life and versus death. Because, sometimes the most dangerous wounds are not the ones that smell. Sometimes those ones who are slow, quiet. It's fast, but quiet and can cause people to lose their blood supply from the inside out. So this is Forgotten Infection Friday on Diabetic Foot Files. And remember, not every black wound is bacterial, okay? Sometimes it's a fungus that's already inside the blood vessels. And this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.